on video here. All right. Good morning, everybody. Welcome to the Parkinson's Disease Education podcast. I have a special guest this morning, and we're doing this as a live interview, a streaming interview. So I hope we get some people coming this morning. I'd like to introduce you to Dr. Jonathan Sackner-Bernstein. And some of you may be familiar with his work or have heard his name before. But in case that's not the case, I just wanted to present the opportunity for Dr. Bernstein to introduce himself a little bit. I guess I could also do that in the form of questions as well. And so thank you for being here this morning and also for asking to be on the podcast. I'm honored that you came on this today. And I wanted to ask you a little bit about your background because you're a physician and you're in the Parkinson's world doing research, but I was going to find out from you, your background is as a cardiologist, correct?
That is correct.
I was going to ask you, for my own curiosity, how you ended up in the Parkinson's research world and the neurology world, and you have this wonderful company, Right Brain Bio. I'd like to learn a little bit more about that. I think our audience would too.
Sure. I really appreciate the fact that you're letting me share what I've been learning over the last couple of years and the possibilities that I see in the future, in the near future, for people with Parkinson's. So thank you for that, Michael.
My pleasure.
Yes, I am a cardiologist, but I'm not your typical cardiologist. I did spend over a dozen years in academic medicine doing clinical trials, helping to run them nationally, internationally at all different phases. But from there, because I was so fascinated with how products are developed and how the science can be realized for clinical use, I shifted from academics, spent several years at the FDA in a senior role, and then worked in the inner circle at the Defense Department's agency called DARPA, which does a lot of, frankly, crazy science. So I had a chance to really learn how to work with people who were exceptional and who had knowledge and skills outside of my domain, outside of cardiology. At the FDA, I was not working as a cardiologist. I was across all of the different therapeutic areas. So it was very humbling to walk into a room where, you can't come in and say, hey, I'm the all-knowing cardiologist here. And all of a sudden, you're just one of the people who are surrounded by some really amazingly talented people. And it helped me learn that it's really our duty in science and in health to ask questions and to fight to remain open-minded. And with that background, now sort of fast forward to the mid-20 teens, a very close buddy started to get worse as he was suffering with Parkinson's.
Okay.
And this was I miss him dearly at this point. Very, very close friend, an inspirational person, one of the smartest people I've known. And one day, I think he was feeling a little down after a doctor's appointment. He said to me, I think you can figure something out to help me. He had this faith in me that, quite frankly, I didn't have in myself. And I kept pushing him away, saying, Ivan, like get realistic here. I'm a cardiologist. If you develop heart problems, I'm your guy. but I'm not a neuroscientist. And largely because he was unwavering in his belief in me and in his ability to be a pushy New Yorker, quite honestly, and just keep pushing on me, I finally said to him, fine, I'll spend a few weeks reading about Parkinson's, and then I'll prove to you that as much as I want to help you, it's beyond my ability. So I started reading, and my strategy was, okay, let's start out by trying to understand what the science is that justifies our current approach. And that was, you just start at the beginning, because basically our current approach started in the 1960s. So you
Exactly.
go back to look at the 1960s. And what was really interesting to me is that I learned very quickly that even though people will cite examples of an individual doing well or something transforming their life despite their Parkinson's, if you look at Parkinson's as a whole, I think it's reasonable to conclude that our approach has been failing since it was introduced in 1960, when dopamine augmenting or dopamine replacing therapies were first advocated. And the entire industry, and when I say industry, I don't just mean pharmaceutical companies, I mean academic centers, clinicians, everything. The whole landscape is built on this false idea that the solution is giving dopamine. How can I make such a strong statement that's a false idea? Well, have we made any progress in conquering the disease since doctors first started augmenting dopamine, supplementing dopamine, using levodopa in the 1960s? No. So it's obviously a false premise, because otherwise we wouldn't be in this situation talking to people who are struggling with the disease. So current therapy is failing. The entire landscape is built on false premises, not intentionally. I think just because of the ways the science has evolved and human nature. And we've identified a mechanism and a corresponding drug that in 9 laboratory models of disease has reversed the pathology by essentially taking away the toxic breakdown products of excess dopamine that's inside these brain cells and allowing these cells, almost like a permissive therapy. The cells know how to fix themselves better than we know how to fix a cell. So if we take away the toxin, and that's what you do by lowering dopamine according to these 9 different laboratory models of Parkinson's disease, the cells have a chance to start functioning again. And we've seen this in other diseases. I learned about this in cardiology. When you treat end-stage heart disease, the kinds of people that go on to need heart transplant as their only way to survive. That was my academic focus. And we learned that if you took away the toxin, which in that case was norepinephrine, which is chemically closely related to dopamine.
Dopamine.
You take that away, the cells start to function. The organ functions better. The people do better. Disease progression is halted or reversed. Not permanently. Biology always wins. But it's reversed and people go back to normal activities, go back to a normal life. I think that's the opportunity here based on these discoveries for Parkinson's disease. So as you can tell, it's a little bit of an unusual way to get here, but it's driven by data. And I think there's reason to be optimistic.
It's a very interesting concept. And to me, I think it sounds like we're on the verge of a paradigm shift, I hope, in the approach to management of Parkinson's. And I wanted to back up a second but thank you for saying what you said about your background. I think it's interesting that you had a personal tie with a dear friend who had Parkinson's, and that led you to what seems like a passion at this point. But I'm just going back for a second to pathophysiology. I wanted to talk about Parkinson's for just a moment and what we kind of know, at least from my understanding, what we know about the disease process, and then tie that in with what you just spoke about. And correct me if you have medical insight that is better than mine, but from what I've taught other people and research on my own, it seems to me that the issue that we have with the neurons in the substantia nigra is that for one cause or the other, whether it's genetic or exposures or whatever, toxins, we have problems with not only the mitochondria of those cells, but which results in reactive oxygen species that causes cell damage. You have alpha-synuclein aggregation that causes cell damage and potentially apoptosis, cell death. Either one of those problems could cause cell death. Would you agree?
Yes, absolutely.
And then further down the road, if you go to the synapse, the synaptic bulb, basically, you have the issues. The alpha-synuclein directly results in problems with vesicle formation at the synapse. Synaptic vesicle formation is a problem. In dopaminergic cells, that translates to dopamine, not only less dopamine. This is where I feel like the paradigm shift is, because in my mind, prior to our conversation or prior to you bringing this up with the interview today, my perception was, okay, that makes perfect sense. You have less dopamine entering the synaptic cleft and less dopamine to be received by the dopamine receptors on the other side. However, that also means on the flip side, you have more dopamine remaining in the cell. That leads to the dopamine toxicity concept, which is that actually flipped a light switch for me. Can you tell us a little bit more about that from a medical perspective in terms of what that does to the cells, and why that's really important in light of what we're talking about?
Yeah, well, I think it might be useful to have a little history to start with.
Sure.
So if we go back to these papers in the early 60s, there's some really fascinating aspects to these 4 papers that were published in the 1960s. If you look at the papers, first of all, to get papers from the 1960s is not always so easy.
Yeah.
You're not going to find these 4 papers online. So you have to find a library that has old journals or can get them through interlibrary loan. But let's say you can overcome that, but it's not so easy like just doing a PubMed or a Google search. You're not going to find them that way. So let's look at those 4 papers. It's very clear you do not need to be a scientist when you look at these papers. Each of them has a very interesting table amongst the data presented where it shows dopamine levels in the caudate and neoputamen, the 2 key parts of the brain where you need dopamine in order to move. It shows those levels in brains obtained from people who had just recently died, generally within 12 hours. And those measurements have been shown to be stable out to 24 to 36 hours. So, I don't think there's any question about the validity of these measurements. And you see the numbers in people with Parkinson's and people without Parkinson's, and the numbers are dramatically different. That in Parkinson's, what they show is the levels are really low. So you see this in 4 groups of patients without any treatment, patients with levodopa, patients with MAO inhibitors, basically in 4 different populations and covering different scenarios, all showing the same thing. And what happened was those 4 papers basically were embraced by the scientific and clinical communities. Look, there's too little dopamine. And in one of those papers, they actually gave dopamine. And they gave it a very high dose because they didn't understand that if you used it with carbidopa, you could use less. So these patients had side effects from high dose, but they also started to move. 15 minutes later, they moved. A short-term immediate response. And everything was set. Now, what's the problem with doing that analysis? I'm going to come up and say there's a problem. So the reason there's a problem is that all 4 of these papers were only published in German. So it's very tempting for someone like me who's a scientist who I can do medical Spanish, but I cannot do any form of German, to look at these papers and focus in on these tables because it's easy to understand it. How do you spell dopamine in German? You just remove the last E and it's dopamine. So you can figure it out, right? It's not hard. Caudate is still listed as caudate. Putamen is still listed as putamen. Those are Latin designations.
Right.
So
it doesn't change.
You look at the papers, you see the numbers, you draw the conclusion, you're done. But what we're taught, certainly as an undergraduate when I was studying engineering, and also when I was in medical school and since, is that the most important part of any publication is the methods section. You have to understand what was done before you know how you can interpret the information. Unassailable, not debatable, non-controversial perspective of how to look at scientific information. So how many people know what method was used in those 4 papers? It turns out I haven't been able to find any, including talking to some of the big shots in the field who eventually, when I told them I had translations of the papers, the request would be, oh, could you send that to me? I'd love to read it.
Wow.
So how did I translate it? At that point, first of all, I had to find a place that had the journals, and there's a place called New York Academy of Medicine that has journals going back to the 1800s all locked away. And you basically give one of the librarians the citation you want. They go down to the basement, find the big book of a year's worth of journals. They show it to you. Is this the right one? They don't let you touch it or leaf through it because they're old. Even the 1960s, they don't let you touch them. Fine. They take them back. They make a copy for you. So I had a copy. I tried doing optical character recognition so I could do translation automatically. It wouldn't. The programs I had wouldn't work. So I literally went to Google Translate and typed in German one letter at a time.
Wow.
And translated the methods, and I learned the following. The way people were measuring dopamine was to take that chunk of brain, the caudate of the putamen, and literally grind it up into a soup and say how much dopamine is there. So that means they're looking at the dopamine that's inside dopaminergic neurons, which are the most important, inside astrocytes and microglia, all those other cells, and mixing it with all the fluid that's outside the cells and creating a soup. So if you create a soup of brain tissue, and I know that sounds very bizarre to say, and I don't want to sound like I'm insensitive to what that represents or the sacrifice people made to donate their brains to science. Please don't interpret it that way. But it is a soup. And you measure the soup and there's low dopamine. That became standard. By the 1980s and 1990s, the literature started to teach us that the amount in the neighborhood, in the county, the wealth of the county that I live in, even if that's good, doesn't mean there aren't poor people living in the next town.
Right.
So you need to know how much dopamine is inside the neurons. So before I started asking this question, guess how many people have ever reported the amount of dopamine inside the neurons?
I've never heard anybody talk about that.
0.
Yeah.
So I can give you tens, if not hundreds of citations where people talk about the importance of knowing how much dopamine there is in the cytosol inside the cell. Nobody's ever measured it. Nobody's ever calculated it. I'm not a laboratory person. I'm really more clinically based, but I'm pretty good in math. So I figured out a way to create a mathematical model to estimate how much dopamine was inside the cytosol of people with Parkinson's compared to people without Parkinson's. And when I did that, and it's based on simple algebra, let me explain to you. So if you know the total amount, and then you know how many cells are lost, and people have counted the cells, and then you go to the axonal bulb, the presynaptic bulb, the axon, and you know how many vesicles are there, because they're reduced. You do it step by step, and you can compare what's in normal compared to what's in people who don't have normal dopamine metabolism, without Parkinson's, with Parkinson's.
Yep.
And what I found was that the caudate had about 87% higher amounts of dopamine inside the cells in people with Parkinson's than people without Parkinson's. And the putamen, it was 360% higher. So that was astounding to me. Astounding.
That's a huge number.
Huge number. And it was evident whether people had been taking drugs or not.
Wow.
So it wasn't just because they were getting dopamine. So this is a big deal in my mind. And
Yeah.
I'll be honest, I was a little scared to share the information with anybody. I thought for sure people would say, that's the stupidest thing I ever heard. So I thought, okay, I'm going up against it, and I have some lessons learned and experience going against the standard dictum, using data to change a paradigm. And I knew that I needed to have really tight data. So I started looking for ways to test what would happen if you reduce dopamine. And I am going to get to your question. I know it might seem like I'm going roundabout, but I think it's
okay.
It's a useful arc for your
The
listeners.
context is important.
Yeah, and if you pay attention to the literature, you'll see that once a month or once every 6 weeks, there's an article that says scientists discover a way to conquer Parkinson's. And what they've done is similar to what I did with that calculation. You find an abnormality, but that's only half of what you need to do to claim you have something with promise. The second half is to figure out how to reverse that abnormality and see if it changes anything. So that's not typically done. I poked around and I figured out, being kind of an old-fashioned drug developer type person, that you can look for a drug that blocks the enzyme that's primarily responsible for dopamine synthesis and see what happens when you use that in models of disease.
Mm-hmm.
So I found a drug that had been approved in 1979 by the FDA for treatment of a rare cancer complication, hardly used at all, but a safe drug, and then found that there were 2 studies that had used this drug in 2 different models of Parkinson's, and in each case reversed the measure of pathology that they were studying.
Wow. Okay.
Since that time, there have been 7 more models where this drug has been used. And I talk to people, the authors of these studies, they talk to me like, oh, you're misinterpreting the data. That's not what we intended. That's why we didn't discuss it in the paper. Well, in figure 3, you've got impressive data that show that when you use this drug to block dopamine synthesis, you reduce the amount of dopamine, you reduce the amount of dopamine metabolites, which are toxic, and you reduce alpha-synuclein deposition in the neurons. Or you reduce dopaminergic neuronal death.
Yeah.
And at this point, there are now 9 models. So apoptosis is reduced, inflammation is reduced, mitochondrial loss is reduced. And that's important because the mitochondria aren't only responsible for making toxins. They're really the energy source for this network of neurons that probably requires the most energy per cell of any region in the body.
So much
density
ATP.
of mitochondria is huge.
You have so much ATP needed in those cells. Yeah.
So dysfunction, which dopamine metabolites cause of the mitochondria, block how much ATP is produced. So you get loss of function, not just loss of neurons. And you put all this together, and as you keep digging in deeper, and I can tell you, I've read thousands of papers now. I mean, I am not the world's expert on every aspect of Parkinson's, but I can stand and toe-to-toe and discuss these concepts with anybody in the field now and feel very comfortable with my command of the literature. And what it shows is that all of those things that you discussed as potential contributors to Parkinson's getting worse and manifesting as movement disorders and other related problems, alpha-synuclein deposition, mitochondrial dysfunction, free radical stress, then there's inflammation. I mean, you can go on.
Right.
All of these things appear to be augmented, increased, worsened by elevated levels of dopamine because of the dopamine breakdown products, which are toxic. Dopamine itself is not, but the breakdown products are. Mm-hmm. And when we see the data using this drug that I want to test in people, in these 9 models, whatever was measured, that pathology was reversed by this drug, 9 for 9. So you have an abnormal mechanism and intervention against that mechanism can reverse pathology in the lab, the logical next step, which the FDA agreed with when I engaged with them formally, is to do a clinical trial. And that's what we're poised to start.
Wow, that's great. So this is a new trial that will be starting. Is it going to be this year?
We're currently on schedule that it could start this year. We've completed our first run of manufacturing the drug, which worked perfectly.
Mm-hmm.
We're now about to start work on taking that drug, which when you make it the substance, it's a powder, crystalline form. We're about to start figuring out how to make it into pills so people can take it. We're still fundraising, but we've raised enough money to do this. And as long as it keeps going at this pace, we should be able to submit by this summer to the FDA for permission to do the first trial, which will put us on schedule to dose the first patients by the end of this year.
That's fantastic news. Just a quick question. Based on what you're talking about with the dopamine toxicity, that concept, I mean, you had alluded to the fact that there were some papers you came across that kind of almost seems like they accidentally found this out, and didn't want to talk about it. It's like, we didn't mean to find that, But I guess I guess my question is, if you count those papers kind of accidentally finding it, but also based on what you have brought to light, how long do you think we've kind of really technically known about this concept of dopamine toxicity?
Well,
it's relatively new still.
Well, I think the way I'm approaching it is new. The concept is an old one.
Okay.
So, I remember back in medical school, so this is in the late 80s, mid-late 80s, one of the things that was discussed, and this was about the extent of my understanding of Parkinson's when I started this. So, a Parkinson's expert would kind of chuckle at my very simplistic understanding. But back then in the 80s, there was discussion that levodopa could be toxic, and therefore you should either not start it or do things called levodopa drug holidays, where you would take people off it for a few months.
I've heard of that.
And what I've learned in this process is I know that levodopa has toxicity, has side effects, has problems.
Yes.
I don't think it's the main driver of this problem that I'm talking about.
Right.
I think the main driver is what the cell is doing on its own.
Yes, the disease process.
The disease process. I think that if you look critically at the pharmacology of levodopa, accounting for what's wrong in the disease, you would come to a different conclusion than what I hear from most people who discuss this. Because they say, well, what's the pharmacology in a normal person? That's not the same as the pharmacology in someone with Parkinson's, because how it's taken up, how it's metabolized, all of those things. People with Parkinson's, because of the mitochondrial dysfunction, don't have the energy to handle the drug the way a person without Parkinson's would do. I'm sorry to say normal versus Parkinson's. That's a little obnoxious, but hopefully people understand. So if you look at the way the drug is handled in a Parkinson's state, it's not getting that much into the cell. And that's where the toxicity is, intracellular, inside the axonal bulb, that presynaptic part of the neuron. So I wouldn't want people to conclude from what I'm saying that I passionately am convinced that you should not be on levodopa. Not what I'm saying. I view levodopa as a terrific drug to palliate symptoms. That's what the data show.
Right.
It definitely works short term. I think if you, again, look at Parkinson's disease versus people without Parkinson's, I could make the argument, I think, pretty strongly. I can't prove it, but nobody can prove me wrong about this either. I can make the argument pretty strongly that levodopa acts more like a dopamine agonist than people realize in people with Parkinson's. And so it can be useful. It's not a long-term solution.
No.
As you go up on the dose, which many people need, more and more side effects that themselves can become debilitating, become a problem.
Yes.
But I wouldn't want somebody to listen to this and say, oh, dopamine's bad. I'm calling my doctor and telling her that I'm stopping it today. That would be bad.
That's important not to do that.
No, don't want to
Yeah,
do that.
yeah. Yeah, so but it's encouraging that you're saying that there is something that will be in research on the horizon that could potentially change the approach to treatment of Parkinson's altogether. If not that levodopa doesn't have a role still, but if you were tackling the pathology of having too much dopamine within those cells, that seems to me to be a better frontline approach if you know the person has Parkinson's disease. Because that also, to me, says you could potentially even slow down the progression significantly. I think you already said that earlier. I apologize if you did. But my thought just now is like, yeah, I mean, if you caught this early enough, you could potentially drastically slow down the disease process.
I think the science suggests that that's the minimum that you would see. There is the potential to reverse the dysfunction. And when I talk to people about that in Parkinson's, I think that there's a limitation because of what they've seen in diseases. You don't see people have reversal that's dramatic of neurodegenerative diseases. It just doesn't happen. We don't know how to do that yet. I mean, I think this will do it, but so far we don't have proof that anything will do it. As a cardiologist, I'm spoiled. I got a chance to be, when I was a research fellow, to be one of the people starting the first phase 2 trial of a beta blocker for heart failure at a time when beta blockers were contraindicated for use because they would make it worse. We figured out how to take a drug like that, a novel way to dose it, that people could tolerate it, and instead of worrying and focusing about what's going to happen 15 minutes or 2 months after you start it, you think about what's going to happen 3 months, 6 months, a year after you start it. And what we saw there is there were people who their heart function reversed in some cases towards normal. In fact, there's a whole area of research in cardiology to say, what do you do with people who started out with very bad heart failure, very weak hearts, who are treated with a beta blocker? They get so much better that not only they feel better, but their heart's now pumping almost like normal, almost normal strength or normal strength. Do you stop that medicine? Do you continue it for life? I mean, that's a whole field that has opened up in the last 15 years because of reversal of the toxin. Not just, so there are cells that are probably sort of, alive and struggling along, trying to do their thing. We refer to them in cardiology as hibernating cells. And if you then change the environment in the heart, we see actually genetic programs change so that they really, not only the genetic program changes, the proteins that are synthesized change, the functions change, and then the organ function changes. It's not just at the cellular level, function as an organ. I think we have a chance to see reversal of the disease. Again, I'm not talking about curing something because biology will win, but that doesn't mean we have to let it win this week, this year, or this decade.
I think that's hopeful and encouraging, and I think that people watching this will hopefully be encouraged by this, because this is, frankly, I haven't really heard of anything more encouraging or, I guess, groundbreaking in the sense of that paradigm shift we mentioned earlier than this. I mean, this seems to be a big pivot that people need to learn about. Now, I was going to ask you, too, about the trial. I guess, would this be a phase 1 of the trial that starts?
The way the FDA used the official language during the discussions we had was this would be a phase 2A trial.
Phase 2A, okay.
So it's phase 2 because we're going to start in people who have Parkinson's.
Got it.
Phase 1 work has already been done on this drug because it's approved, even though hardly used. It was approved in 1979, so we can go right into phase 2A.
Got it. Okay, so that's very interesting. So that the drug that we're discussing is basically will be responsible for the dopamine reduction therapy. Okay.
Yes.
So I guess the question I have follow up to that is, you're probably looking for trial participants, correct?
We're not looking yet, but we
Oh,
certainly
okay.
will be.
Okay. I guess in the meantime, well, I could certainly say that. Would you be open to having people reach out to you about questions or anything regarding this before then?
Yeah, I mean, people. I mean, unfortunately, I can't answer everybody's questions. So I mean, as I started talking more and more about this, I'm starting to get more and more emails. So I do. I mean, I read them all. I do try to respond. The way I will most commonly respond is trying to roll up questions and comments
Mm,
and addressing them in a weekly newsletter that I put out.
okay,
So I've been
that's
doing that
great.
for the last 6 months because the volume of emails has just gotten to be too much for me. So I put out a newsletter every Wednesday morning. You can sign up at parkinsonsdisease.blog.
Okay,
And certainly if you Google me, I think it'll come up as one of the sites, hopefully near the first page or two, but parkinsonsdisease.blog.
got it. Okay. And Right Brain Bio is your company, so there's social media as well as probably the website and all that for that. Yeah, so I guess that sounds like a place to go directly would be probably the blog, and you could sign up for the updates if you're interested. And that would be a way that you can kind of summarize those questions into an article for people to read. We've covered a lot in 35 minutes. I feel like there's probably more we could cover, but I don't know what else to ask you at this point because it seems I feel like it's just such an amazing concept to me, and I'm really appreciative of the opportunity to actually discuss this with you because I feel like we're kind of on the edge of something that will be groundbreaking and in how this disease is managed in the future because the dopaminergic therapies or dopamine replacement therapies to this point, as you mentioned multiple times, definitely can manage the symptoms, but it doesn't really do anything to address the disease process or to reverse Parkinson's. Now, this is something that I might bring up for selfish reasons, but one of the things that I've been interested in learning recently is how we can there's definitely a place for pharmaceutical approaches, but I love also the concept of induction of autophagy and mitophagy through either dietary changes or concepts like photobiomodulation. So obviously there's a place for that too, but I feel like it's even more important that there could potentially be a drug for this as well. It's both and I feel like, but
Yeah, I think if you become, I mean, from a practical point of view, I have to be very focused.
absolutely.
But I think that for those who are affected by Parkinson's, either because they have it or a loved one has it, those who are treating patients, either as a physician or some other form of health professional, you've got to be looking at all possibilities.
Yeah.
And whenever you do it, go back to those first principles, the basis. And I think, finding time, which is not easy to do these days, but finding time to go back to the original data, the original research that
Yeah.
forms people's perspectives is an opportunity to learn things that can be quite useful. And look, even if I'm wrong about this, one of the things I want to emphasize is the importance of asking questions. People like to talk
Yes.
about themselves as being skeptics. Skepticism to me oftentimes comes across as dismissiveness,
Right.
as opposed to people being curious
It's not
and asking
inquisitive.
questions.
Yeah.
Right, being inquisitive, that's a great word. So, I think that, you want to be looking ahead. You want to be looking to the left and right. You want to look up and down. You want to look behind you. You've got to be looking and thinking and trying to do so in a way that's constructive and that builds some hope that we can figure this out.
Absolutely. I advocate for lifestyle change to my audience because even though, again, I'm not dismissing or reducing the value of what you're producing or what you're researching at this point, but at the same time, there is so much lifestyle adjustment that needs to be made anyway that I feel like if you can improve your quality of life as something like this dopamine reduction therapy is being developed, that's still just as important. And also continuing your current drug regimen. But, anyway, that's why the reason I brought that up is because lifestyle changes, you can't, it's kind of hard for people to hear, I think, but you can't really just go on living the way you used to live once you have a Parkinson's diagnosis, because what we know of the disease, in my opinion, basically is saying, you can't just eat the same things you always ate before. You have to drink water, not soda. You have to, you know what I mean? So there's so many aspects of lifestyle, sleep habits. Anyway, I know that's beyond your scope of.
I mean, another way of thinking about that is also that it's, even though it's really expensive and complicated, it's much easier to test a drug or a device than it is to test lifestyle.
Oh, absolutely.
A perfect example of that is exercise.
Yes.
If you look at what exercise does to skeletal muscle, we know that when you're really exercising, you're building up mitochondrial number and function, which means you've got more energy, which you want.
Yep.
It's the same signals throughout the body. And I can't help but believe, and I cannot figure out a way that anybody could prove this to be true or not, that if you're involved in intensive exercise, that there's a chance you're improving mitochondrial number and function in the striatum.
Absolutely. Well,
now, how are we going to prove that? We're not going to prove that. But
exactly.
If you talk to people who start exercising regularly, and God knows I should be one of them.
Me too.
What you find is that people start to feel better.
You feel better.
Is that because they're helping their Parkinson's, or it's related to other physiological changes? I don't know, but who can argue with somebody feeling better?
Absolutely.
Right? Even if you can't prove it. So I think that what you're saying about lifestyle is often overlooked by the traditional medical community, which I'm part of, and shouldn't be. So I'm glad you brought that up.
Not knocking that at all, but just saying that, that is something I feel like needs to change in the entire health industry, is looking at that holistic perspective.
Yeah.
But I realize that it takes a lot of time and energy, but that's definitely important.
Yeah.
I didn't mean to go up on a tangent. I apologize. I just thought that I wanted to mention that, and also I'm glad to hear your opinion too on that. That's the main things that I had to ask with you today, and I think that we've covered the gist of it. I wanted to leave with a question of if I guess, what would you think? What was the number one takeaway that you would want the audience to get from this in terms of, looking to the future, and how can they help you, I guess, is my question.
Well, the main thing that I'd like to do for people with Parkinson's right now, given where we are in our development of this drug, is that there should be hope. People dismiss the importance of hope. I think hope is incredibly important, especially when facing a disease like Parkinson's. So there's hope.
Absolutely.
And that hope should be palpable, because despite the fact that we're stuck with our therapy from the 1960s that really doesn't work adequately, we've identified a drug that has great potential to reverse the pathology. And at the current rate, we're going to be going into phase 2 and dosing our first patient by the end of the year. So to sign up for the blog, where I'm trying to bring hope and information, and share that with others, and keeping the dialogue going as to why we're not just going to sit back passively and let the disease win. I think those are the things that I try to communicate as much as possible.
That's very important. Hope is absolutely a very important thing to consider, and we all need that. But that blog site is parkinsonsdisease.blog. So that would be a great thing, I think, for people to consider reading the blog and signing up as a subscriber so you get those updates from Dr. Bernstein. Do you have any final thoughts today? I don't think there's anybody live for a Q&A, so that's what I've been, which is okay. But
really appreciate the chance to share this with you and with your audience. Thank you for what you're doing.
My pleasure. So this will be a public video soon, so I will let you know before I do that so that you can look at this. Actually, I can send you a replay link before we do that. Yeah, I appreciate your time, and I appreciate you asking to be on, and I really enjoyed this conversation, and really am excited for the future, and excited to learn more too, of your work especially. So
thank you so much, Michael.
My pleasure. Everybody, thanks for watching and listening, probably later at this point, but appreciate everybody who's a member of the channel and supporting us. You'll be able to watch this before it goes public. So thank you for everybody being here in the future. And thank you, sir. Have a good day, and we'll talk to you later.
Thank you so much. Bye-bye.
Bye-bye.